easy. I thought I'd come and do something for 2 minutes. But Dr. Albano is going to finish talking about CBT. But partly for technological reasons and due to the exact opposite of what Dr. Albano just taught us, I'm going to show a little clip from Showtime that talks about the stigma surrounding antidepressant treatment in children. So we don't have to switch back and forth between slide sets because the video is on a different set. So it's a little out of order. But my point with this, other than this is the most entertaining I'll be for the rest of the afternoon, so you can leave now, is to show you the association, the stigma behind medication treatment, particularly in children. And it's from a Showtime show called Weeds. So again, it's kind of a soft R. So there's no one under the age of 12, hopefully. Yep. Let's see if this will work.
How to go change strength yesterday.
Doctor wants to put him on antidepressants.
Drugs are not the answer.
This from the king of all things mind-altering.
Illegal drugs, not this prescription antidepressant zombie shit that fries your brain. Weed makes you hungry and happy, and in your case, financially insolvent. Oh God, I've been there.
Andy, it's not funny.
He's 10 years old, and his dad died. Drugging him so he acts like everything's fine, it's totally fucked up. When my ferret killed himself a few years ago, I took Celexa. I gained 40 pounds, I couldn't ejaculate. Is that what you offer your son?
Anyway, the doctor says that it's just temporary till his neurotransmitters realign themselves or some shit like that.
See? Even you don't believe it. Trust me, those antidepressants are evil. It does not mean them.
Hey, I'm trying business. Maybe I want to be on it.
Excuse me?
Sherry Phillips started taking Zoloft so she wouldn't cut herself anymore. Now she's in a band.
Can she ejaculate? For the most reason, drug your child and wander through his use like a robot.
Yeah, let me. Come on, Mom. Say yes to drugs.
So now we'll do our deep breathing and calm down for recess. So I just want to, again, you kind of see, obviously I'm not endorsing marijuana as a treatment for anything, but there are lots of perceptions of prescription antidepressants being risky. Part of it stems from the fact that, in all honesty, we don't know exactly what they're doing. We don't have the defined pathways. And there's a lot of misinformation and just lack of information out there. And I think the important thing, whether you prescribe medicines or not, as clinicians, is to be informed of what we know and to be honest about what we don't know, so we can help frame medications where they belong in the treatment paradigm. And the other reason, besides my own laziness, why I didn't want to talk beforehand, because with anxiety disorders particularly, but also depression, especially for children and teenagers, really the emphasis should be psychosocial treatment. Cognitive behavioral therapy is a very well-validated technique for the whole host of anxiety and depressive disorders. Medication may have a role when integrated with therapy. And I think that, and we wanted to present that today. I didn't want to inadvertently lead with medication to overemphasize its role here. So I'll let Dr. Albano finish her piece, and then I'll be back to bother you.
Where did you get that from?
It's from Weeds.
Weeds.
Yes.
I don't know that show.
I've never seen it before. Someone
Oh
told
my
me
gosh.
about that.
It's so much healthier than girls, which, anyway, yes. So, yeah, we are going to talk much more about integrating our work. But let's do a little bit more here on the CBT. Behavioral, now we'll get into the behavioral or the action-oriented parts of the treatment. Behavioral exposures for anxiety. Look, here's the thing. When kids are anxious or people are anxious, they start avoiding and escaping from situations, which takes them out of the game. If that little boy never went back to t-ball, his last memory would have been being yelled at, missing the ball, not knowing what to do. That memory, as we heard this morning, emotional memories stay with you for the long term. You ask an individual who's in her 60s or his 60s about their first panic attack, it may have happened 45 years ago. They're going to tell you everything as if it was happening right there and now. Emotional memory is strong and laid down. So what happens is then the longer they avoid, the less experience they get with actually coping in these situations and managing the situations, and they learn more realistic probabilities that, yeah, there's sometimes you'll have a coach who yells and there's sometimes you won't. And there's sometimes you'll catch the ball and there's sometimes you won't. And there's sometimes kids will be, getting everybody together, and there's sometimes that, they'll be going their own ways. There's all different ways things go. But the more you avoid, the less you learn in terms of how to cope and manage. So exposures this is one of the easiest things really and truly to do in your office. You making exposures work depends on you being creative and you being willing to get out of the therapist chair and do with the kids what they need to learn to do. This is why I love New York City, because my office is in Midtown Manhattan, right near Central Park, on top of one of the main subway hubs. So we've got rats, and we have people who are, dirty and smelly. We have buses and traffic. We have bees and birds in the park. Anything I need to expose, we can create the scenario of mom walking away from a kid in a crowded situation and, being lost and scared. We could do it all right from where I am, and I love putting kids through these things. It's great because they learn how to cope. I actually had a resident in psychiatry who I had him take a 14-year-old boy for the first time on a subway. The teenager had panic disorder and separation anxiety. And the thing was, he had to learn how to ride the subway so he could get to his school. The resident lost the kid in the subway. So I'm sitting in my office. I get a phone call from the resident. Oh, my God, Dr. Albano, I lost my patient. So he was having a panic attack. The kid, though, had the wonderful experience of realizing Dr. A, his last name is Ed, Dr. Eric was missing. He got off the subway at the next stop, went up onto the street, used the cell phone and said, Dad, hi, it's me. I lost the doctor. And the father said, where are you? I'm at such and such street. Okay, go back down, get on the subway, take it uptown, and I'll meet you. The kid got to problem solve and deal with the situation he was afraid of, and I had to get my resident medicated. So it's like, my gosh. All right. So the thing of it is, and then, yes, we wrote the paper. So the thing of it is, you get to do things with the kids. The thing of it is, that John March used to love to talk about this. If you're treating OCD and somebody's afraid to touch the toilet, you're sticking your hand in the toilet first. We always show them what we want them to do. And I have all kinds of recipes for making gross stuff that is, thank goodness, it smells like it and it looks like it, but it ain't it. You name it, I'll tell you how to make it. In these exposure situations, it gives the individual a chance to practice the cognitive restructuring skills, to coach themselves differently, to practice the somatic management skills, but to deal in real time with the situation. We use the fear and avoidance hierarchies and climb up those. Those are their targets for treatment. You get into gradually more challenging situations. Decrease the use of safety signals. Leave the cell phone at home if we're going to go and do this at school. You can't call mom. Night lights get turned off. Different things like that, right? Safety signals come in all shapes and sizes. That one kid, I won't go in the cafeteria without my friend. That friend is a safety signal. You see, we have to work on helping them be comfortable doing these things on their own and teaching the parents to appropriately label, I like how you handled that, I'm proud of you for coping in that way, and to decrease their coaxing and urging and lecturing and all that. No. We want to use differential reinforcement. In terms of exposures, we define a very simple situation. Not very simple, but we define a situation, define the goals. They have to tell us how they would feel in the situation in terms of or what they're thinking in the situation rather, and how they feel in terms of their rating of anxiety from 0 to 100, 0 to 10, whatever it is. And most exposures are around 10 minutes if you're doing it in the office. 10 minutes and you do it again for another 10 minutes, and 10 minutes for another 10 minutes, Because it's not just once. You want them to do these things again and again. And then oftentimes we take them out in the street. Let me just see. So here's an example of an exposure. Starting a conversation for a teen who's socially anxious, doesn't like to introduce themselves and start conversations with other kids. The goals have to be things that any of us can observe. I will introduce myself. I will ask 3 questions. I will speak in a volume that they can hear me. The automatic thoughts, I won't know what to say. She thinks I'm such a geek. And challenging those thoughts is, I don't know what to say, sort of implies you're the only one who should be speaking. Why do you have to carry the whole brunt of the conversation? All right? Why is it up to you to come up with things to talk about? She thinks I'm a geek. Again, how can you know what she's thinking unless she tells you? These are ways you challenge these thoughts. The rational thought to be thinking really is, in a conversation, I'm only responsible for 50% of it. Unless I have a certain mental disorder where I talk to myself all the time. No, no, no. That's a different treatment, not me. Okay? But it's really, you are only responsible for 50% if you're talking to another person. If you have 2 other people there, it's 33 1/3%. 3 other people, 25%. Hey, the more friends you make, the less you have to speak. Okay? But, we get into humor with the kids, too, because they got to learn to laugh at this. And this is the way we set up an exposure, and then we have somebody role play. If it's just me and the child in therapy, we'll do that, but a lot of times, like I run 2 social phobia groups a week, and they're great because they could practice with one another, okay? After the exposure, we review and process how did it go. Classic exposures that we do in our clinic, we start out doing role plays in the clinic, and then, like I said, we take them out. One of my favorite exposures is to take the kids outside. I make 3 or 4 of them at a time, go into different restaurants, sit at a table, sit there, and maybe they get water, they get the menu, and send the waitress away. She comes back at the natural, waitress will come back, are you ready to order yet? Not yet. Send her away again. Can I take your drink order? No, well, just water for now, thank you. Send her away again. They have to turn her away 3 times. The 4th time, I'm sorry, we've changed our mind. And they get up and leave. Assertiveness. And what's the big deal? I have faces looking at me like, how can you do that? Believe me, it's New York City. This waitress is making money. Those 4 teenagers, but this is helping them to be in a situation that's uncomfortable. People with social phobia feel they're imposing on people all the time and feel they can't do these kinds. They can't ask questions of store clerks. They can't say no to something. They can't turn back a steak that was sent to them that is medium rare instead of medium well. Whoa, whoa, whoa. Or the wrong order that they get. No, this is helping them to see in the world. Sometimes you change your mind. It's okay. You get up, you leave the table, someone else is going to take it. These are the types of things that we do in vivo, in the real world. All right? So, and we challenge then what happens. What happens to your anxiety doing that? And then we say, take them from one restaurant, send them to another, because I want them to do it again after we've processed what happened. Because sometimes they'll have a waitress who says, okay, see you next time. And sometimes they'll have, gosh darn, wasted my time. This is New York, but that's okay. That's all right. They got to get used to personalities. How many of you have worked with parents who they play chess with their child and school with teachers? Oh, that teacher doesn't fit my child. No, no, no. We have to work to get the best classroom with the best teacher, and the teacher who's the nicest, and she's not. And they jockey their kids around. Finally, they go through all the classrooms. There's no one left. The child needs to get used to all the different types of personalities. Because what are you going to do? You're going to go with your kid to a job one day and sit there with them? No, they have to get used to it. Over time, in working with these kids with anxiety, over the course of an exposure, their anxiety goes from being high and it decreases because they're learning how to manage the situation and stay focused in it and mindful in the situation instead of internalizing everything. Similar to exposures or behavioral activation tasks, this is where we want kids who are depressed to get engaged in activities that may bring them positive feelings or better feelings about themselves. So social activities or things to do with peers and family members, from going out for pizza to having somebody over to watch a movie on TV and make popcorn, success activities, studying, completing assignments, going to a part-time job, physical activities, doing something physical, and I do a lot of prescribing yoga and mindfulness type of stuff for my teenagers these days, including, organized sports maybe, Relaxing, self-soothing activities, playing my guitar, listening to music, taking, a nice bath, things like that. Depression leads to, in the behavioral model, the work of Peter Lewinson from way back in the 70s demonstrated that depression and the withdrawal associated with it leads to a decrease in what's called contingent reinforcement, response contingent positive reinforcement. When you start withdrawing, you're not engaging in the world in such a way that it interacts with you and reinforces the things that you do and say. So you get this feeling that nothing's rewarding out there, what's the point? And it's like a vicious cycle. Well, the more you withdraw, the less reinforcement from the environment you're going to get, the more you're going to feel bad, and the more you're going to withdraw. And the environment's just like, what's the point of calling him? He never goes out with us. I'm not going to even bother to call him anymore. So behavioral activation comes out of that tradition of the Lewinson approach to depression, which is you've got to engage and activate the individual to take part in things again. And one of the, they have shown, of course, research has shown healthy activities like physical exercise, eating well, having good sleep hygiene, things like that, improve a person's mood. We prescribe these, and a lot of times this is where I'm okay with a safety person. I want them to do this with a friend or a relative family member, especially in the beginning stages of getting kids activated again, because they're more likely to do it if they're accompanied when it's depression. So that's okay. Now, parents. Can't live with them, can't live without them. What are we going to do, right? Parents in the treatment process, whether it's anxiety or mood issues, they're drawn in. And we don't belabor the questions that they usually come in with. How did we do this? Why is this child different than my other kids? What have I done wrong with him? Right? They feel guilty, they feel responsible. We work with that sum around the point of looking at maybe risk factors, looking at things that are there. Maybe there is a lot of marital discord. Maybe there are psychopathology issues they're not dealing with. We've got to work some with that, but the main thing we have to really focus on is what are you doing now that is not helping your child to move themselves along? And we need to change the way you've developed your parenting of this child, because it's not facilitating them in making the changes they need to make that are positive for themselves. So how can we engage you together to deal with this? So we need to understand where they are. Oh, look, I finally realized how to use the pointer. You have to understand. Whoa, we're only 3 hours in. Examine the maintaining variables and teach them to be the coaches that are the proactive, effort-focused, right, reinforcing coach as opposed to a negative coach. We do more involvement of parents with younger kids, but I'm getting to more involvement with teenagers and their parents in a way that facilitates the parents letting them do what's developmentally appropriate and tamping down the overprotection. We have to look at the way the degree of anxiety and mood are interfering in functioning, and how can the parents help to promote in certain ways. But what are ways that the parents' own pathologies are in the way? Sometimes if I have an affected parent with OCD who can't, get control of their own OCD, I'll work with the non-affected parent. But, I have had people call and say, please treat my child. Here's the issues. We talk on the phone. We set up an appointment, and then they say, oh, I'm sorry, I'm housebound with agoraphobia. I can't come. And it's like, we have to get some treatment for you, because I say to parents, it's like treating the crack addict and sending them back to the shooting gallery. How long before they're going to relapse because you haven't tried to make the changes you have to make too? So we have to look at parental psychopathology and dysfunction and deal with some of that. Ancillary treatment for the families, family therapy, couples therapy for the parents, individual therapy. We try to see what we can refer them to. And we're looking at the parents being focused on rewarding or labeling positively the child's active and courageous behaviors, trying to get them to extinguish the withdrawal and fear behaviors by not attending to it. Systematic ignoring. all right? Control their own issues, communicate, cope, and problem solve with the therapist and the kids, all right? So we want them to be consultants to us, cheerleaders for the kids, coaches for the kids, and also clients as they are part of some of the targeted interventions. A lot of the work we do with parents, especially with young kids, sticker charts, privileges. I had a parent call me up and tell me, this was with a child with ADHD and anxiety actually, we were out last night, he begged me, I bought him an Xbox, now this morning he won't listen to me, we need to leave the house, he won't get off the Xbox. Oh. Okay, you saw the picture of B.F. Skinner, it's Skinner 101. We have to teach this parent, reinforcement comes after the behavior you want to, to improve. The kid had promised the dad in the store he'd be good. I'm sure he's good at the Xbox now, but so I had to teach that parent as we teach others, first they do the behavior, then they get 10 minutes of the Xbox or whatever the thing is. So parent training and all the standard ways you've learned about it goes into these treatments. And the main thing is, in therapy, you're transferring the responsibility of conducting the treatment from you, the expert, to the child. Eventually that child has to be, or teen has to be, the expert in handling their anxiety or depression. And a lot of times what we do with this is we videotape a commercial where they teach other kids how to handle the issue that they just dealt with. We also help them to clue into, and we don't distribute or sell those videotapes. The child takes it home with them to keep and watch themselves, to remind themselves. You have to help them put all the elements of treatment into the videotape so they know what to watch. And we look at, if you feel relief, you need to expose or activate yourself. If you feel relief because someone canceled on you or plans were changed and so forth, that means you have to examine why. Why am I relieved about not going to a party, not seeing a friend? We do booster sessions and things at planned times of high stress, beginning of school, after vacations, and so forth. Why don't we do this? I could either do the outcomes or I could let you do the outcomes. Or, you could do your thing. This is all research now.
Yeah, I'll get into some of the outcomes, and you can, as I go through, you can add stuff in the individual studies.
Yeah, so why don't we move, because I want you to hear the pharmacology and then let us get to combined stuff. Just know CBT works. See, CBT works, CBT works, CBT works.
I'll make
sure
I say that.
CBT works. Any questions while we're booting up? Yes?
Like I said before, I work in the school districts, and we do struggle with this whole school phobia thing. What we're struggling is therapists keep them home while they work with them.
Look, no. Oh my gosh.
We have that happen more times than it should happen. How often, I'm also oversee like the 504 plans for our students in our district, and this would be very appropriate to develop a plan for a student with one of these phobias or anxieties or whatever. But do you do that? Do you give that? Accommodations to the schools, like these are the things, because, doing that therapy in the office is great, but then the parent can't get them to go through the front door of the school, and we're still at square one. What are you doing to help the schools, I guess?
Yeah, so the question here is, how much accommodation when you have like school refusal behavior, whether it's anxiety, depression, or whatever. Let me say this. Since I'm like no more running, I'm not running for president anymore of any of these associations I used to run for president. Be very tempered in what I say. I'm no longer. Okay, ready? Homeschooling is akin to feeding a diabetic child sugar. Okay? And accommodations, to a certain degree, you may as well, hand the kid marijuana and let him just smoke himself, because you are giving into the anxiety. So we have to try to get in there as early as possible to prevent the child staying home from school. And parents, if they're homeschooling because of religious, political, ideological stuff, that's one thing. But even those parents, I say, that might be fine. You might be, counterculture. I'm schooling my kid, organics, and we're going to eat vegetables, whatever. Fine. But your kid is also afraid to go to school because of social interaction. You got to put your beliefs aside because that kid needs school to be socialized with other kids. So accommodations for us, we work with goal-directed. We do certain behaviors that we ask the school to accommodate for a certain length of time with and we get the parents. We only give these letters and do this if parents sign on 100% that they're going to work with us diligently and to do everything we can to turn the child around. And I'm never going to homeschooling or home tutoring. I might go to alternative schooling in like an assisted type of program where they pick the kids up and bring them to a children's day unit or something. But we are not going to homeschooling. I don't do the co-sleeping thing for the separation anxious kids. I mean, get over that with the family bed already and all that kind of stuff. So I could go on this I'm going to let Jim talk. Jim's got to talk. Oh, you got a hot topic you just turned me on to. We'll talk at the end. Oh, because I had to appeal to all the wider constituents of the APA, all those crazy people. Sorry. Sorry, go to Jim.
2 marijuana references. I didn't see that coming. I do have some disclosures. In the last year, I haven't gotten any money directly from any pharmaceutical company, but I do research work which goes to our university. None of these make antidepressant agents or anti-anxiety agents. They're all ADHD companies, so it shouldn't be a direct impact. Okay, so we've talked about why treat depression. This slide's a little bit dated, but apparently if you average in Europe, suicide moves up to number 2. I don't know what it passes. You'll have to look that up. But in terms of important information, this is CDC data from the mid-2000s. It's gotten a little bit better, but 17% of teens report suicidal thoughts. As we've heard, it's very common. 9% acted on them. That's fairly scary. 3% needed medical attention because of a self-harm event. So, I mean, that's 1 out of every, you take 2 classrooms worth of high schoolers, 1 of them has been in the hospital because of a self-inflicted injury. That really is one of the most important reasons why we need to treat depression. Turns out, though, contrary to media reports, most adolescents with depression don't receive any treatment. And the newest data from the National Comorbidity Study says that anywhere between 15 to 20% of adolescents who meet criteria for depression take medication for it. So that's a fairly small percentage, which may be good because many of them may not need it, but it's far from the truth that the vast majority of adolescents endorsing depression are medicated for it. It's actually the exact opposite. So this is to put you to sleep. There's just a lot of antidepressants. And the point of this talk is to provide psychoeducation, because as clinicians who aren't prescribing, I think the most important thing is to be aware of the treatment options, where they fit in the treatment rubrics, information about their risks and benefits. As it turns out, there's a couple of these that have been very well researched. There is no one drug that's the best fit for anyone. We just don't know how to do that yet. So you just need to know what they do, what they don't do, and which ones are riskier than others, or really which ones aren't researched as much. So there's really absolutely no need to memorize anything off of that slide, other than to scare you. And there's even more. There are a few that are generic. So when we talk about medications for children and adolescents for depression, it turns out mostly for anxiety as well, but we'll start with depression. We're really talking about what we call selective serotonin reuptake inhibitors, or SSRIs, sometimes called SRIs. This is the Prozacs of the world. I'll use trade names for recognition, but traditionally we'll refer to generic names. So the fluoxetine, but known as Prozac. It was the revolutionary antidepressant of the late 1980s, early 1990s. Turns out that same thing is the most well-studied medication in children and adolescents. So when it comes down to kids, it's all about what we studied and what's proven to be safe and at least partly effective. And to date, it's this entire class of selective reuptake inhibitors, and mostly fluoxetine or Prozac, as we'll go through. There are a few differences between the meds, which again are relatively minor. The big difference is how well they've been studied in kids, because historically what happens in every disorder but ADHD and mental health, we look at what's been done in adults and say, well, that ought to work in kids. And that's what people prescribe. So there's very little data specifically for children, especially for prepubertal children. That's gotten a little better lately, but as we've studied more, we realize it's not the greatest idea to just extrapolate from adults. Things turn out to be a little bit different. Most of these meds work by impacting neurotransmitters in norepinephrine and serotonin. The newest meds, i.e. the most expensive meds, are really just reformulations of older medications. There is no real value in paying more money for a medication for treating depression and anxiety in children and adolescents typically. Co-pays throw this all off, but in terms of the actual costs, actually what's been around longer is more studied than what's newer. Just from a pharmacokinetic or a biochemical level, there's a couple of interesting differences with adults. Norepinephrine-based medications are thought to be more effective for adult depression. They're particularly associated with pain relief. For example, there's one agent called duloxetine or Cymbalta that's heavily marketed for diabetic pain, neuropathic pain. Turns out that's not very well tolerated in children. So what's thought to be a very strong antidepressant in adults is not what works okay, but has a whole lot more side effects than what we might see in adults. So again, kids are not the same as adults. So how do antidepressants work? Because that's inevitably a question I get asked by kids and parents, and it's a very good question, which we have limited answers to. But there are a couple theories that have some decent scientific data behind them. So I'll try my best to shortly summarize them. But it is very complicated, and any one model is going to greatly oversimplify probably what's going on in the brain. There's really 3 levels we want to look at. The first thing all these medications do is they block a transmitter. They affect individual neurons in the brain. They increase levels of chemical release between neurons or nerves. And that pushes chemicals out from where they're resting to where they need to be in between the nerves to create excitation, activation. So that's an immediate effect. There's an immediate effect in neurochemical levels being changed in the brain. And that's what serotonin is. It's one of these transmitters. That's why they call it a selective serotonin reuptake inhibitor. It prevents it from going away, stays in the nerve longer, it activates the nerve. But that happens right away, and most people who have had experience with these medicines know that they do nothing in the first day or two, typically. At least nothing beyond the effect of giving anyone a sugar pill. So that's probably not the primary mechanism of effect, because that happens too quickly to really be driving most of your symptom relief. The brain is very adaptable in an annoying way sometimes. You do one thing to the brain goes the other way because it wants to stay in balance. So what happens when you push up these neurotransmitters, the brain creates more receptors. It kind of cleans the synapse. It cleans the space in between nerves. But sometimes more receptors can be good. And actually, the disease state does this as well. In depression, we tend to think there's lower levels of resting neurotransmitters. And the brain adapts by creating more receptors because it wants to get everything it can. And for example, in suicides, when we do autopsies, we see more receptors. So the brain tries to adapt in a good way, but the brain's own adaptive abilities may impact the efficacy of these medications as well over time. The last thing, and probably the most important thing, is these medications down the road affect genes. Genes actually make new proteins, which lead to making new, regrowing nerves, making new receptors. There's almost a restructuring of the brain. And this probably is what drives it, and this takes a while, and that turns out tends to correlate with symptom relief. So we're constantly getting a new reformulation of why these medications work, but all these steps seem to be relevant. And for example, again, we do have some proof. If we look at the brains of depressed adults, at least, we see certain parts of the brain are smaller than they should be. They've atrophied, they've shrunk, just like a muscle shrinks if you don't use it. And then when you give fluoxetine, which is again Prozac, you see these parts of the brain actually get larger. So there is some science behind our understanding of these medications. This is a limited drawing from the Archives of General Psychiatry. There's a very good article about trying to understand why these medications work. Basically, 2 nerves, pre and post, neurotransmitter, for example, serotonin, in the space in between the synapse. And what seems to happen in people who are prone to depression, because as you heard, one depressive episode predicts another depressive episode, there are some people who are biologically predisposed, to be more prone to depression. So they don't need as much psychosocial distress to develop symptoms of depression as someone who's not predisposed. And for example, this enzyme that leads to breakdown of these neurotransmitters in here. If it's very active, you kind of run low. And that seems to be a risk factor in some studies for having high recurrences of depression, high levels of this enzyme MAOA. And we are starting to be able to look at that as possibly a biological risk factor for getting depression. And that may be why some of these disorders run in families, and they tend to be hereditary. What the medications do, really, is it's a little purple thing here. They block the chemical from leaving the space in between the nerves, leaving the synapse. But all that depends on how much you had to begin with. And that's the limitation of almost all the medications for mental health. They can kind of reroute the system. They can put stuff from where it isn't working real well to where it should work well, but we can't really make more of these neurochemicals, these neurotransmitters. So if you just don't have much, there's only so much you can do. And if you really have very little, we can't really do much with the medicines. So there are some people who just aren't responsive. Everybody's on them. Again, that's not true. But there's a perception of that in the media. Like I said, 15 to 20% of adolescents who report enough symptoms to be depressed are prescribed an antidepressant. And if you can actually see numbers here, this is 12 to 17. And we're talking 2 to 3% of children. Actually, those are adolescents at any point in time, maybe up to 4% if you add in the females, are taking antidepressants. FDA-approved antidepressants. Remember that huge list of like 40 things? There's really only a couple antidepressants that are approved by the Food and Drug Administration for use in children. That doesn't mean you can't use the other ones, but it means these are well-studied medications that we have. We know the most about their response rates. We know the most about their side effects. And most of them are approved only for adolescents. So fluoxetine or Prozac is approved down to age 8 for treatment of depression. It's also approved down to age 8 for treatment of obsessive-compulsive disorder. So by nature, that tends to be our default choice. It's also generic, so it's very inexpensive. Let's see. And then escitalopram, which is marketed as Lexapro, is approved for depression down to age 12, so 12 and up. There are 2 other antidepressants, the generic version of escitalopram called citalopram or Celexa, and sertraline or Zoloft, which is a very common antidepressant that's been around. They have data in kids for depression. And then there's 1 or 2 other studies that have very mixed results. So all those other 36 agents, they basically have no data specifically in children and adolescents for the treatment of depression. So you can narrow that huge slide down to fluoxetine, which is Prozac, and then for adolescents, escitalopram, which is Lexapro, plus minus 2 other generic agents, which have some data showing some effect. So it gets much simpler. So the one thing most people know about antidepressants is about 6, 7, 8 years ago now, there was a really big concern that had a whole bunch of government hearings that antidepressants may backfire and make people feel suicidal and actually might be leading to completed suicides, particularly in children and adolescents. Some of that concern has died down, but typically this is what parents will know. And this will immediately raise a question, which is a very good question. Can these medicines actually backfire and make things worse? And it's important to understand the history behind the trials here because it actually explains a lot of the problem that came up. What happened is if you know how medications are funded, like I said, all the medicines that we use come from adult trials. And in 1997, there was a federal law that said if you test your medicine in kids, we'll extend your patent, which if you're the number 1, 2, 3, 4, 5 selling drug is millions and millions and millions of dollars over an extra 6 months just for extending the copyright before the thing goes generic. So all these smart, economically driven drug companies did all these trials in kids for no real purpose other than to say we did the trials. They were very poorly done. They were never really designed at the end of the day to be the best measures of how well the medicines work. So they did things, for example, like never asking kids before they came into the study, have you ever felt suicidal? And as you've heard, suicidal thoughts are very common, particularly in depression. If you don't know if it's happening at the beginning, once it happens after you give the med, it sure looks like it's from the med. So the database that this comes from is very, very flawed. There were no measures specifically of suicidal thoughts in the vast majority of the studies. It would just come up when a parent or a child happened to report something spontaneously, which is far from a scientific way of doing it. So the most important point here is the data behind this is flawed, but it still produces some useful outcomes. It also produces a whole bunch of trials that never came to light that should have, that show that antidepressants don't work for children. Mostly because child depressive states tend to resolve on their own, particularly if you enroll kids with very mild depression. And again, these initial studies didn't go out of their way to find sick kids, because in all honesty, they may not have wanted sick kids because they're tougher to work with. So it made it look like the meds don't work either. When you look at studies that are done that enroll more seriously depressed children, the meds still don't work for everyone, but they do outperform inactive, fake, or placebo medicines. Not gigantically, but they do. So the other important point of the FDA was this question about whether the medicines can actually backfire and make kids feel suicidal or make adolescents more suicidal or more likely to act on these thoughts, which again, we have a very limited capacity to answer this from the way these studies were designed. But it's important to know that there were 4,000 children or adolescents in studies that the government was able to review. Nobody completed suicide. So that alone takes the severity down a little bit. There were 95 cases identified as true suicidal events. So there was some genuine intent to harm yourself or some actual attempt to harm yourself. So again, we're looking at a fairly small number, particularly because these are all kids with depression. Overall, 4% of children experience what we call an adverse emotional response, which is basically reporting as feeling more depressed or anxious. It doesn't necessarily mean you reported feeling suicidal. When you compare that to the rates that we saw with placebo, you're about 1.5 times more likely to feel more edgy, to feel emotionally worse, or to express suicidal thoughts than someone who was given a fake pill. But you have to remember the base rate is very small. It's about 1 in 400. So you increase your chance from about 1 to 2% to about 2.5 to 3, maybe 4%. So there is a small percentage of people, or a small percentage of kids or teenagers, who are more likely to feel worse emotionally. And if you feel worse, you may be more likely to feel suicidal or to express suicidal thoughts. But that's probably about 2 out of 100. You compare that to the number of people who feel better, and that's a much larger number. So it puts the risk-benefit ratio in your favor, but we do have to recognize if a parent really says, my child looks more anxious, depressed, agitated, or irritable on the medication, that could in fact be true, although that's far from the likely outcome. But there were no completed suicides. What the end of all of this was is the FDA created these new labels, this big black warning called the black box that said there is a risk of new onset suicidal thoughts or action or self-harm events, and put it on all antidepressants. And I think it's good that this issue came to light, but what it led to is a call to not use antidepressants at all in children and adolescents. And partly that might be justifiable if you had other alternative treatments, such as therapy, that was suddenly going to be made more available. The problem is the American healthcare system has a lot of barriers to accessing therapy. It doesn't have nearly as many barriers to medication. So what seemed to happen, at least initially, is we had less medicine use, which arguably could well have been a good thing. But all the studies that came afterwards showed no real increase in therapy uptake. Really what happened is, okay, so we dropped antidepressant use, especially in primary care, because you have to remember most doctors prescribing these medicines are not psychiatrists. There's 6,000 of me across the country being a child psychiatrist. I mean, there's probably more pediatricians, almost as many pediatricians in the metro New York and DC area than there are child psychiatrists. There was no increase in therapy. So what happened is we had a large increase in not getting any treatment. It almost tripled. The number of kids getting no treatment who were diagnosed, who had an insurance claim for depression, skyrocketed. And that's a lot different than shifting people from one treatment, such as medicine, to another treatment, such as therapy. And this plots this out. The black box was effective in reducing the number of antidepressant prescriptions. Here's where it hit. This is where it was going. And there should have been no real reason it was increasing dramatically. So that's probably a good thing. But it started to decrease in terms of the overall prescription rates. And again, the most important thing is the therapy rates didn't increase. decrease. Just another way of looking at it, and you can see specifically in the youngest kids, we saw the greatest decline after the black box warning, which again, in and of itself, may be a good thing, but if you're coupled with no other uptake in treatment, it's probably not. The big debate was, is the increased use of these medicines actually leading to more deaths? This is very hard because as we talked about with suicides, there aren't that many, and many deaths that might be considered suicide aren't necessarily labeled as suicides, particularly the younger the child. So this is an article by Bridge that was in JAMA that got a fair amount of press. They actually tried to look at this. So here's the suicide rate, which had historically been trending down, hadn't been skyrocketing, which was a little bit kind of against the argument that the increase in antidepressants was causing this problem. The black box hit, and suddenly we had a spike. That these are your error bars. So statistically, that shouldn't have happened. That was too much of an upswing. Should just explain it by chance. So then everybody was running around saying, you're not treating. Maybe that's because there's more suicides. The good news is actually leveled off a little bit. And then the depression and the economy went into the tank. And even in kids and older adolescents, there was probably a little bit of an increase from that. But the overall message is clearly there's been no decrease in suicide rates in adolescents since these medicines, since the use of these medicines have gone downhill. Possibly, although we're not clear if it's related, there was a temporary uptick. And then over the last 2 years, the rates have trended up slightly again, but that may be more due to economic distress than anything else. So it didn't do what they wanted it to do. So let's talk a little bit about treatment data. I think this has been referenced once or twice. This is one of the largest multi-site study for adolescent depression. I bring this out just to show that there is evidence behind what's been done. The Treatment of Adolescent Depression Study, or TADS, and this study is nice in that it really tried to be fairly inclusive. It tried to get real-world, significantly depressed adolescents, although it did exclude imminently suicidal youth, people who might be needing to be going into an inpatient unit. But you could have suicidal thoughts and be enrolled. So this didn't go for the easy, clean patients who fix themselves after 2 weeks. These were chronically depressed adolescents. They could have other disorders, such as ADHD or a host of anxiety disorders, and a good percentage of them did. And it looked at multiple treatments. And that's really the impressive part. It looked at cognitive behavioral therapy. It looked at fluoxetine, which at the time had around, I think, already gotten approved for adolescent depression, and that's why they picked it. They looked at the combination of the two, and then the percentage of the kids received a fake pill or a placebo. One of the controversies is when you got both med and therapy, you got real med. When you got the med alone, you got a blinded med. You didn't know what it was. And obviously, if you got placebo, you got you didn't know what it was. You weren't told you're getting placebo. So that's mixing the med and the therapy is confounded a little bit by those people who knew they were getting real med. Very traditional dosing. The initial trial went for 12 weeks, and the kids were reassessed every 8 weeks. I don't remember the model. What was the CBT program used in TADS? Was it newly designed?
It was a combination. The CBT program was a combination of the Beck type of cognitive approach and the Lewinson behavioral activation approach. Plus, we had family modules, and so it was a little more. It was standardized for like 6 sessions, and then you had flexible modules to use.
So certainly very traditional dosing with a very traditional drug and a fairly intensive, well-established CBT regimen. So none of the treatments were research-based in that they had been very well-established treatments, but the actual efficacy in real-world patients, was the question at hand here. And the good news is kids got better. Those getting both treatments, 71% were significantly improved. This doesn't mean you were remitted. This means you were improved enough that, at their definition, thought that would make a real-world difference. 60% with med, 40% with cognitive behavioral therapy, which was one of the surprises, and I'd be interested to hear your comment on why. And then kids get better over time with depression. Particularly just bringing them into a trial is in and of itself activating. They're coming out of the home. They're coming to the sessions. Even if it's just a physician like me asking them a bunch of questions about if the pill's bothering them, it tends to be a bit supportive, and it tends to be rallying the parents around them. So there is a large effect of coming to see even a medication visit that can be impactful for depression. The overall effects were fairly large, except again, cognitive behavioral therapy was a bit disappointing. Suicidal ideation, because this study actually measured it at the beginning, smart move, So they could see that it got better. 30% of the subjects reported at baseline. By the end of the 12 weeks, only 10% were reporting it. If we had never measured it, the headline might be 10% of people taking medication have new onset suicidal thoughts. But again, they measured it. After, over time, therapy caught up to the point by about 24 weeks, or even earlier, it had caught up to drug. And by the end of it, 36 weeks, and the sessions, these were kids now in maintenance therapy. And when did maintenance end?
36 weeks.
Okay. So the visits were much more spaced out now. Even despite that, therapy now was performing as well as medication plus therapy. All the kids were doing pretty well who had continued to receive treatment. And here you can see the response rates 36 weeks out. They're all in the 80s, no matter what treatment you got. So therapy took longer to take root, but caught up in the end. And you can see this visually. You get a little bit of a jump start with the med, which is the diamond, and therapy lags a little bit through 12 weeks. But then we gradually catch up, and overall there's a fairly significant improvement. This is that Children's Depression Rating Scale, which is copyrighted still. I looked
It
on the
is,
web.
okay.
Very good scale, though. I like it. And generally speaking, the lowest you can score, I think, is a 17. Anytime you get below 28, we're pretty happy. 40 tends to be a cut point for depression. So the kids aren't necessarily asymptomatic. And this doesn't mean that their functioning is great, but it's definitely better. They're receiving over a 50% reduction in their symptoms. So do you want to comment on your thoughts about the CBT response at 12 weeks?
Yeah, the thoughts about the CBT response. First of all, we took a well-established treatment, the cognitive therapy manual, a well-established treatment, the activation behavioral manual, and we put them together. Each of the, and we did fixed components, and then we had the flexible menu of do you need communication training, parent problem solving, blah, blah, blah. The point being, we made a new treatment, and we didn't give, the criticism from CBT world is we didn't give enough of a dose of one modality or one approach, really, and there was too much variability in what could be chosen by the therapists, as we moved along. It would have probably been better to use the approach by Lewinson or use the approach by Beck, but we wanted to make the field happy. We shot ourselves in the foot. And then the other thing is that you do need more time with CBT.
Right, so if you want to get a response fast, or you need to get a response fast, there may be some beneficial effect of medication and compared to cognitive behavioral therapy over that. But if you have time, at the end point, you're going to get to the same point. And typically, the side effects are going to always be much less with therapy than with medication. You may have to consider costs and time commitments in the real world as well. But you'll get to the same endpoint, if not potentially better in some realms. 1 in 10 teens treated for depression still had some suicidal thoughts at the end, despite their improvement in symptoms. So just because they're looking better doesn't mean they can't be suicidal. There was some initial encouragement that actually cognitive behavioral therapy may be particularly beneficial for reducing the kids who backfire on med. That unfortunately hasn't been replicated in other studies, although it makes intuitive sense. You give people the skill set to manage adverse sensations, they should be able to better handle the adverse effects of medication as well. But we can't sit here and say therapy reduces the risk of bad emotional responses to medicine. Depression is treatable. Both interventions work. So you do have 2 very effective treatments, which in the short term may have some additional effects when combined together. You just have to be respectful of the amount of time it takes for each to work and the additional side effect burden of medication. This was a large study, it's over 400 kids, so there were a number of kids, like I said, with anxiety and ADHD. There wasn't a lot of effect in terms of the comorbidity. It turns out depression severity had more impact than what else you had, but there were a couple interesting findings, I thought. Those with anxiety tended to respond better than those with severe ADHD or ODD, and this has been replicated in the ADHD literature. My take on that is always anxiety tends to promote compliance with therapy. ADHD tends to promote noncompliance. So whenever you're doing a psychosocial intervention, at least for the therapist, it's better if the person has anxiety than for ADHD. Depression and anxiety, the medicine seemed to be particularly helpful. But then when you got into the disruptive behavior disorders, the combination treatment looks even better. So the need for behavioral services probably increases because you're addressing a whole other domain of impairment. So the problem with these studies is, well, what do you do if you don't respond? The study all ends. They don't tell you what to do next. Just like a recipe. If it doesn't turn out, what do you do next? So we've tried to keep up with that. So this study called Tordia, and for the life of me, I can't never remember all the mnemonics, but they all have to have a mnemonic.
Treatment of resistant depression in adolescents.
There you go. So this was really the next step study. These are kids who had tried antidepressants and had suicidal thoughts. So we're ratcheting it up a notch. You had to have had experienced some suicidal thoughts, and you had to have failed at least a trial of antidepressants, not so much in a research setting, but in real life settings. So what do you do when the first thing doesn't work? Because for many kids, medication, due to ease of access, is the first thing. And what they looked at is very common sense approaches. Not so much which drug is the key, but what kind of modality works. So we could add either one of these traditional SSRIs like Prozac, one of these high-powered norepinephrine drugs for things like venlafaxine, which is marketed as Effexor, or we could add therapy, or we could do both. The good news is when you did something more, 50% got better. So a failed initial response does not doom you to be a non-responder. You keep trying. Things can get better. Switching meds and adding therapy improve more people than just switching the med. That, again, seems to be a very common sense approach, but it's nice to have data. If you don't respond to a med, adding therapy to it can be very helpful. And if you don't respond to the first med, you can switch the med and get a better response. But this is one of the things where I mentioned earlier that little kids aren't adults. These more high-powered antidepressants that we use in adults, it didn't turn out to be any more effective than traditional serotonin-based drugs. And in fact, they had larger side effect burdens. The kids found them harder to tolerate. So don't necessarily shoot for the big guns from the adult literature. Sticking with what we know and has what been researched in children seems to be a better track. Okay. Just some practical tips. Again, when a discussion comes up, there should be a rationale as to why you're not going to use fluoxetine or Prozac, because that's the one that's FDA approved. It's the one that's the most studied, and no other medication has in studies found better results. So if you're not going to use it, which there are circumstances why you might not, you really should have a justification. The other agent that's approved for adolescents is escitalopram or Lexapro. There may be some slight advantages to it for certain adolescents over fluoxetine. So it can be in the ballpark. Sertraline or Zoloft is very good data in children for obsessive compulsive disorder. So at least we know in the age range, and it's been studied in adolescents and children with depression in at least one trial. So it can be in the discussion. And so can a medicine called citalopram or Celexa. Paroxetine or Paxil is the agent that actually kicked up this whole brouhaha about medicines backfiring in kids. And it has a couple properties that turn out to be a fairly poor fit in children. It tends to wear off very abruptly, and it may cause some physical effects as it wears off, and it tends to have very unpredictable blood levels as you change the dose. So this should be an agent, and again, I have no financial input in any of these companies, and they're almost all generic now, that you probably shouldn't use unless you have a pretty good rationale to use it. And then a few others like fluoxetine, which is marketed as Luvox, which is generic, has been very well looked at in anxiety, as we'll see, but never looked at much for depression. Newer adult antidepressants generally haven't been studied very much or don't have very encouraging data. So stay with what's known. The stuff from the 80s and early 90s works just as well, if not better, than the stuff from the last 5 years. Side effects. As far as we can tell, there's no major developmental impacts to date with using these medications in developing kids or adolescents. There is a slight effect on clotting time, so kids can bruise a little bit easier. It actually turns out to be very helpful for people who had a heart attack. Depression and a heart attack responds very well to antidepressants. It reduces the rates of future heart attacks. It doesn't help your average 12-year-old, but it's helpful for adults. We talked about suicidal thoughts. Either feeling less tired and awake when you're not supposed to, or more tired when you're not supposed to, tends to be the most common side effect. So always ask about changes in sleep patterns. Headache, physical hyperactivity, which is always fun if you already have ADHD. We'll talk about this concept of switching into mania. Some stomach side effects. This sense of feeling medicated is relatively uncommon in kids and adolescents, especially if you dose things gradually. And then sexual side effects are very common in adults. The parents are all very excited when I tell them that their adolescent may be less sexually driven. Though you can't bank on that. It's not effective birth control. So switching into mania. Mania or bipolar disorder. Lows of depression, highs of mania. The classic movie image is the person who goes on the coke bender in Vegas and drops all their money, which is hard to do when you're 8, but you can, although if you really put your mind to it, you can have manic episodes in children. They're relatively uncommon, but you can get them. And there's been a long-standing concern that depression happens before mania. So we treat what we see, and it turns out some of these people might turn out to have bipolar disorder. And particularly depression is more likely to onset in adolescence, and the mania may follow in young adulthood. So we could turn out to be kind of wrong by treating the depression and kick people up into mania we've unmasked their bipolar disorder. That being said, the rates of that are extremely low. True prepubertal bipolar disorder is very uncommon, and even adolescent onset bipolar disorder is relatively uncommon. So treating what you see is probably a safe thing. You do need to remember that these medications do make some people feel a little bit more restless and feel a little bit more awake at night. That isn't mania. We will have parents who get very concerned about that. You also have to remember, particularly for anxious kids, if you relieve their anxiety, that doesn't necessarily mean they're always going to make better choices. If you've been anxiety-bound for years and now you have much less inhibitions, you may not have very good practice making good choices without your anxiety, particularly for our ADHD youth who have anxiety. You're just freeing their impulsivity. So that can look like mania. Mania is really an abrupt switch with a rampant uptick in hyperactivity, decreased need for sleep, so not feeling tired, and really high-risk behaviors. That would be much different than you would tend to see just with mild physical side effects. So general advice, remember that antidepressants aren't banned for children. There's no reason you can prescribe them. You should have a reason for using the medicine, especially if you're going to give it before therapy, because that's really not what the evidence support. You should have a reason to, if you're not using Prozac, why you're using another drug. You got to see the kids back, because there is a small chance they could get worse instead of getting better. And the general rule of thumb is give it a go for 6 months if you're seeing an improvement. And then over time, particularly for those who are completely remitted, you can start to taper the med. It is a recurring disorder, but we generally don't like this concept of people growing up on Prozac just to be preventative. So if they really do remit, the priority for kids is to get them off. Don't stop the treatment, continue to monitor them to make sure they do well. And that's another big reason to continue on with psychosocial interventions. If they have a recurrence, then you may want to start considering preventative medicines for future relapse. But one episode of depression should not commit you to lifelong medication. So we'll do anxiety now, a lot of which we've already talked about. So you've got a very good review of the anxiety disorders in adolescents already. For treatment purposes, for medicines, I'm going to box them slightly separately. The first box is separation anxiety disorder, social phobia, generalized anxiety disorder, and panic disorder. OCD gets its own box. PTSD gets its own box. These boxes are basically designed to tell you that the treatments from a medicine standpoint are the same for these disorders. OCD is a little bit different, and PTSD is a whole different ball. So if you have multiple ones of these, which is very common, the good news is the same medication may work for all of them. And actually, the same medicine works for obsessive compulsive disorder. You just have to dose it a little bit differently many times. So group 1 responds to antidepressants and older SSRIs and older antidepressants called tricyclics. They're very hard to tolerate for many kids. Weight gain, sedation, potential chance for heart arrhythmias, and they're fatal in overdose. So not the best drug for someone with a high rate of self-harm behaviors. Group 2, obsessive compulsive disorder. There's a very high rate of comorbidity with ADHD, so always something to watch out for. It too responds to serotonin-based antidepressants like Prozac, just that typically at a higher dose and at a longer treatment course than group 1. Group 3 has a whole different kind of underlying pathological cause and different wiring issues within the brain typically. So, and there's very little data in how to treat post-traumatic stress disorder with medications in children and adolescents. So that's really a therapy-based intervention because we just don't know what we're doing with medications for that yet. So role of medications. What I've always been taught, and I tend to stick by, is the therapy should be at least given 3 months unless it's a very severe case, you're having suicidal ideation, or there's concern about other comorbid symptoms such as psychoses, bipolar disorder, or something else that would need to be urgently medicated. And like I said, exceptions. Severe symptoms, this is always tricky. The families who won't go to therapy or who can't access it due to cost. We certainly try as prescribers to address the motivational impairments to attend therapy, but then you get into a dilemma of no treatment versus some treatment. Child unwilling or unable to benefit from therapy. Concerns arise about the age of the child, although the same things are there for antidepressants, and the intellectual, the cognitive capacity of the kids to benefit from therapy. You have a general rule of thumb as if how young you go for CBT or cognitive.
We're down to
developmental
age
level.
3 for CBT, parent-child interaction therapy,
Okay,
but
well,
we take
we're
into
8 and
account
up for meds,
preference.
so.
Yeah, preferences are important.
All right, so medications are very commercialized, and that's always been a concern. And it's unfortunately what, like I said, particularly primary practice doctors, pediatricians, family practice doctors, that's what they know, that's what they have access to. It's very simple and not very time-consuming to write a medication in a primary care visit. It's much harder to describe what therapy consists of, to help with motivation, to attend therapy, to even find a therapist, other than simply say, call your insurer. And that's typically what happens, and the parents find that very hard to follow through on, whereas the doctors can directly provide the medication. So it's not so much that I think in most cases we're being paid to write medicines. It's a systems issue, that the easier course of easier access, unfortunately, is medication, which tends to drive the use of these things. So it's the same meds, so you don't have to sit and listen to me twice again, that we use for anxiety as we use for depression, for all intents and purposes. And again, it's always an issue of weighing risks versus benefits. We do have data, and actually there's now been a meta-analysis of antidepressants in terms of how helpful they work for anxiety and depression. So you take all the individual studies, you glue them together, you look at them and see, is there a trend across all the studies? Because your average study may be 100, 200, 300 kids, but when you try to look at all these different factors, it turns out to not be enough kids to be able to get a finding. So you put them together and see what we see. And overall, the medications work about 50% of the time for obsessive compulsive disorder. The trick is when you have to remember, especially for internalizing disorders, that sometimes a fake treatment can be fairly effective. Not quite as much for OCD, but about 1 in 3 kids will have symptomatic improvement from a placebo. Now remember, a placebo is embedded in a whole lot of other treatments that we do within a study. So this doesn't mean just wait it out. This means that some of the impact of the drug may not come directly from the drug, and the other service is packaged with it. That's really what it means. But overall, you need about 6 kids. 1 out of every, if you treat 6 kids, 1 of them is clearly better off for having taken the medicine. It's okay. But it's not something you necessarily want to run around with and give to everybody the first time you see they present with OCD. When you look at non-OCD anxiety, the separation anxieties, the social anxieties, the phobias, 70% of them respond to drug. A little higher response rate for placebo, about 40%. But now we only need to treat 3 kids. NNT means number needed to treat. It's how many kids do we have to treat with the treatment to be guaranteed, at least statistically, that 1 of them is better off. So for every 3 kids you give medicine, you can pretty much be sure at least 1 out of the 3 is better off than if you're not given the medicine. That's a little better. Depression, higher, similar rate of response. Here's the trick with depression. The concept of giving a medicine is very powerful for depression when embedded with other treatments. So about 50% of the time we get improvement. And that makes it much harder for the drugs to outperform it. If half the kids are getting better with an inactive drug, I can only do so much better with an active drug. So it takes about 10 kids taking an antidepressant to be guaranteed that 1 of them was better off, for sure, for having taken it. So what this really means is consider alternative treatments, because the medicines aren't going to be a guarantee of better response for the majority of kids. It doesn't mean don't treat. This is in no way meant to show that. These are comparison rates versus all the other things that are done in research trials. So for anxiety, children responded as well as teenagers, but for depression, the response was lower than if you were 12 years or less. So medicines work okay for anxious kids and teenagers. Medicines for depressed kids, which is relatively uncommon, don't tend to work as well as medicines for depressed adolescents. So we shouldn't be real excited to run around and lead with medicines for depressed kids under the age of 12. So the same issue of safety was extended to the anxiety disorders because these are the same medicines. So could you backfire and make an anxious kid suicidal or more suicidal? And it turns out the rate of doing that is much lower, mostly because the rate of anxiety, children with anxiety disorders having suicidal thoughts is much lower. Suicidal ideation is more common in depression. It's less common but can exist in anxiety. So number needed to harm is the flip of that. It's kind of a morbid phrase, but it's basically how many kids would I have to give a treatment to be guaranteed that one of them is going to be worse for having had the treatment. And the numbers are in the hundreds. So it's about 1 in 200, 1 in 100, 1 in 150. So you're talking 1% to 0.5% of kids may be worse off for having had the treatment. Those numbers are much smaller than the numbers we saw on the prior screen. So the risk-benefit ratio tends to be in the favor for most of the disorders, but it doesn't mean you're going to get a response with every medicine. It doesn't mean medicine should be the first choice. What's been studied? So there are several studies for anxiety. For one drug that wasn't used for depression, which is fluvoxamine, or Luvox, which is a generic drug available here, has a pretty good profile in anxiety disorders for this box of anxieties, the separation anxieties, the social phobias, the generalized anxiety disorders. Traditional dosing helped kids 75% of the time had a positive response to medicine. Nearly 3 times as high as the placebo rate, that's pretty good. Took about 6 weeks. Problem is with most of these medicines, we don't know ahead of time who's more likely to respond. There's really no good way of figuring out if that child's going to do better on that med or if that child's going to do well on any med. You kind of have to give it and just see what happens. Like we saw in depression, if you don't respond to one med, you may respond well to another med, even though the meds aren't that different, although the numbers are much smaller. Most common side effects that we saw in the anxiety kids were tiredness and hyperactivity. And just remember, hyperactivity alone or an increase in activity is not mania. We don't need to be worried that they're becoming bipolar if they're a little bit more restless. Obsessive-compulsive disorder studies. This is 12 weeks. It's a little bit longer, and traditionally obsessive-compulsive disorder takes a longer time to respond to a medication than our other anxiety disorders. This, again, was a nicely done study because it compared cognitive behavioral therapy, sertraline, or Zoloft, which is approved for OCD in kids, or both, or placebo. 112 kids, and again, they could have real-world issues. They could have ADHD, but they couldn't be depressed. They could be on other meds, like Ritalin for their ADHD. And what we saw is pretty traditional dosing. And again, combined treatment did better. But the drug came in a distant third. So unlike depression, combined treatment was pretty good, but these response rates aren't fantastic. OCD tends to be a little bit more difficult to treat. Therapy outperformed drug and wasn't that far off the combination of the two. And the response rates to fake medicine were fairly low. And that's usually what you see in obsessive-compulsive disorder. You can't wait it out. It's not going to get better on its own. So again, both treatments work, but therapy, cognitive behavioral therapy, was really the standout in this. So it should be your default first treatment. I like this study because this basically tells me that I don't know, that physicians have their limits. As much as we try to think I can do cognitive therapy and squeeze it into a med check, even if it's a 30-minute med check, I can't. I don't think I'm making anything worse. But this is actually a study designed to do that. They had the doctors prescribing the meds. They tried to integrate some basic CBT techniques into the sessions and wanted to see how that compared to traditional CBT or meds alone. And if you look at the response rates, again, traditional CBT performs very well, 70% respond. Doctors trying to do CBT in a short time frame. Not that physicians can't do it, although I don't know that necessarily should be the first people doing it. We don't do it well if we're not given the time and training. So just because I know how to write a med doesn't mean I know how to do CBT, and I freely admit that. Although the first patient I ever was, second-year med student, Krasky and Barlow, isn't that a famous?
Yeah.
Yes. I did that. I got an agoraphobic woman to drive, and I was in the car behind her on the highway. So that was my initial treatment experience as a second-year med student. And I wanted to be an orthopedist at the time. I was wondering what the hell I was doing. But you just can't cram in one or two principles of CBT into a med session and think that it's really going to be powerfully impactful. It can't hurt, and it might help a little bit, but it's not the same as doing all the steps. The individual steps and the time with the patient and adjusting the hierarchy are very important. Me picking one goal and say, when I see you back in a month, you're going to tell me how many times you're able to walk out to the mailbox by yourself, can't hurt, but again, it's not the same. So CAMS, which is, tell me again, child anxiety.
Child,
multimodal
adolescent,
study?
anxiety,
That's
multimodal
close.
study.
I got a mnemonic
You
block.
can't be a researcher unless you could do acronyms.
I'm in trouble. So 500 children with anxiety disorders. Again, this is the mixed box. The separation, the social phobias, the generalized anxieties, not OCD, not PTSD. Again, nice study because we looked at therapy. They looked at sertraline, which is a very commonly used med for anxiety disorders, although not approved for anything other than OCD, for 12 weeks. And we compared the response, or the combination of the both, or just getting a fake pill. So a very high response. If you remember a couple slides back, much higher than we saw with OCD. 8 out of 10 kids responding. Did pretty well with CBT, about the same with med. Placebo, about 1 in 4. So all treatments worked. The combination was the most effective on some outcome measures. Serious adverse events, this means suicidal thoughts or self-harm events mostly, were not more likely with the med. Again, most likely because anxious kids don't have real high rates of suicidal ideation, but comorbidity with depression is common, so you should check for depression, and you should always query for suicidal thoughts. We saw physical effects of the med, tiredness, restlessness, and sleep delay, and we certainly didn't see that with therapy. So even though the numbers are pretty comparable, you have physical side effects with the meds, which in an anxious kid, in my experience, if you start doing something funny to their body, it gives them something more to dwell on. So in kids with a lot of somatic anxiety, the meds can be tricky because it just gives them another focus of their worry. You need to, and you need to prepare families for that too. So again, even though the meds look pretty good, adding therapy to the meds helps, and the therapy always typically is going to have a better tolerability rate. So you might as well start with that. So again, I know you were a campsite. Do you want to add anything?
Just
to
that we excluded kids with major depression. So that's,
Okay.
yeah, this was a not depressed
All right.
sample.
So it's rigged to have
It's rigged.
relatively low rates of suicidal thoughts.
Yeah.
So what I would say out of that is if you're not suicidal, it's highly unlikely the med's going to make you feel suicidal. So I want to end with benzodiazepines because if you ask most non-psychiatrists, physicians, what you should treat anxiety disorders with, you'll hear Xanax, if they're old enough, Valium, Klonopin, stuff like that. Turns out there's only ever been one study of these in kids that I can come across, maybe 2. Maybe there's a Klonopin one now. But when we looked at Xanax, it didn't work. There's very little data. And these are controlled substance meds, so you do have to watch. There are ways to kind of get high and euphoric from them if you're creative enough with them. They're nice because they work right away. And most antidepressants take a week or 2 or more to work. And they're nice because if you have that kid who's just not going to do something, like go back to school until you can have a little bit of anxiety relief, it's something maybe you could use. The problem is they wear off during the day, particularly short-acting ones like Xanax, which is a generic of alprazolam. So often all you're doing is bumping the anxiety 4 hours down the road, which doesn't necessarily help. And quickly teaches people to just take another pill, which is not what we want to have happen. So there may be some short-term benefit, but in terms of resolving the anxiety disorder, there's no evidence that these are very helpful. So they should never be used alone as a standalone therapy. They may have some small role when you integrate it with therapy, particularly, again, in my experience, with helping kids to move to a clearly defined next step, like walking in the door to school. But I wouldn't otherwise just prescribe them as a de facto treatment for the disorder. thoughts on, Ben? Do you see much, do kids come into you on these things?
You know, they will prescribe them for school refusal to try to get them in the door of the school. That's about where we see it as an initial treatment, but then they move to an SSRI.
Yeah. They can be mixed with antidepressants and are safe, but the main side effect is sedation. So to give these in the morning so you can go to school, then you put the child to sleep. It's kind of a mixed bag. So what is a treatment success? Remember, most of the studies are geared towards symptomatic improvement, not necessarily always towards making the disorder go away, and certainly not towards maximizing the child's function. So all those percentages are in terms of were your symptoms notably better. It doesn't mean that you're necessarily functioning a ton better. And again, with just like with antidepressants for depression, antidepressants for anxiety disorders, we generally want to use, get effect, and then take off. Some things like obsessive compulsive disorder, which may have a longer and more protracted course, you may want to continue on longer. But if you have 6 months of sustained improvement, particularly if they're making use of therapy and have new skills involved, the response typically should be to try to wean the medicine. Because again, we don't want kids growing up on the medicines. There's no clear risk they're bad, but there's not definitive evidence they're completely safe. And then you do get into areas like getting pregnant on the medicines that may have some effects on the fetuses and newborns. So I always end with this. So if anyone have ever seen me talk before, I apologize, you had to sit through it twice. But this is my little slide to show, this is actually Calvin and Hobbes, who's more my ADHD guy. But this is meant to show that Calvin, and that's his stuffed tiger Hobbes, who had terrible ADHD at the age of 8, you can all overcome your psychiatric impairments. And if nothing else, you can go on to be an academic clinician later in life. So thank you for listening.